This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2012, all rights reserved. My name is Doug Lair. I'm an Associate Executive Director for the AARC, and I welcome you to today's webcast titled, The Role of Checklists in Reducing Critical Care Readmissions. Upon completion of this webcast series, participants will be able to, number one, list at least 4 reasons why a patient returning to the ICU after discharge to an acute care floor is of concern to the unit caregivers and administrators. Identify factors that predict return of a discharged patient to the ICU. Quantitate the degree of increased mortality occurring in patients returning to the ICU. And describe desired components of a checklist used for assessing patient readiness for transfer from the ICU to an acute care hospital floor. I am pleased to introduce to you Dr. Charles Durbin. Dr. Durbin is the Medical Director of Respiratory Care at the University of Virginia Health System and Professor of Anesthesiology and Surgery at the University of Virginia. He has published extensively and has over 30 citations currently listed in PubMed. He has a long history of service to both the AARC and the Society for Critical Care Medicine and is recognized as a fellow in both organizations. Charlie is an associate editor of the Respiratory Care Journal and a past president of the Society for Critical Care Medicine. He is well known to respiratory therapists as a speaker at numerous state and national scientific meetings. Dr. Durbin discloses that he has no conflict of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Charlie, welcome to the program.
Thanks, Doug. It's a pleasure to be here. I hope everybody can hear me. Looks like some folks are saying hello, so I guess I'm online now. This is an area of interest of mine for a number of years, and I'd like to spend the next 40 to 45 minutes talking with you all about some things I've thought about and things that I'd like you to take away. I'd like you to learn that patients that leave an ICU are going to come back, and I'd like you to have an appreciation for just how likely that is and how frequently that occurs. By the end of the talk, hopefully we'll know that it's not a real good thing to be readmitted to an ICU, and we'll know what things we might look for in those patients. In fact, there is no survival benefit from coming back to an ICU, we don't think, although it's probably better if you're in the process of experiencing a critical event to get back to the ICU as quickly as possible. There are many cost implications from readmissions for the hospital and the ICU, and you'll know some of these by the end of the presentation. Can we predict who these patients might be? And probably more importantly, can we prevent these readmissions? Finally, I want to spend some time discussing a new tool that the AARC has engaged in creating for assessing, perhaps using your own practice to assess the risk of ICU readmissions. Well, an interest in patients coming back to the ICU is not a new concept. This article, which was published 30 years or so ago, described patients who were leaving an ICU, a medical ICU in particular, and were then readmitted. And this is the abstract from that paper. I'm not going to read it to you entirely, but in this medical ICU over a 1-year period, there were 512 admissions, and 36 of those patients were returned. Now, as a summary to this, of those 36 patients who were readmitted to the unit, that was a total of 12% of the total patients. However, the mortality rate in this readmitted group was over almost 60%, making it a huge concern for the patients, their families, and us. 53% of these patients were admitted because of recurrence of their original problems, suggesting that perhaps they had been discharged too soon, or the resources necessary for their continued care were not available where they were triaged or transferred to. That, in fact, could be a potential problem of quality in the discharge decision. The overall unit mortality of patients was 7% in that study. So being readmitted raised that mortality a huge amount. It's not just medical units that have problems with readmissions. This study, a couple of years later, was published in a surgical ICU. And the patients in this study, there were 721 recorded admissions with 68 readmissions. I'll break this down for you in the next slide. The surgeons are interested in looking at blame, so they reviewed every patient that got discharged and readmitted and decided that at least 62% were probably had problems that should have alerted the caregivers that they might be in trouble. However, they didn't compare those patients to patients who were discharged and didn't come back. So it's a little bit suspect. Of this group, 9.4% were readmitted. The readmission was related to the original disease in these surgical patients by 65% of patients. And the mortality for these readmitted patients was 26% when their overall unit mortality was about 7%. So they were coming back, they were doing less well than original admissions, and most of them were either inadequately or treated or had developed progression in their primary disease prior to or after discharge. The surgeons liked the idea that perhaps they could identify these patients, and they studied that readmission group fairly carefully and suggested that if a patient had a warning sign, they should either have their discharge delayed, maybe a lateral transfer, meaning to another unit, or, and remember, this is a time when we didn't have pulse oximeters and there weren't step-down units in many areas. They suggested that perhaps a step-down unit should be set up to help prevent these costly and potential lethal patient outcomes. They identified these signs that you see up here: a fever within 24 hours, PCO2 greater than 45, or a PO2 less than 70. That would have been on a blood gas, and there is no saturation associated with it. The urine output relatively low. Something wrong with the kidney, heart failure, sputum, purulent sputum, an infiltrate on chest x-ray, or perhaps abdominal distension or absent bowel sounds. Notice that over half of these relate to the respiratory system. If you add in cardiac, you've got pretty much our domain, and we'll come back to that as time goes on. But do remember that that was in fact done in a single unit, and these signs were picked up on just simply looking at the records of those patients who came back to the unit. I got interested in this problem when I had a critical care fellow named Robert Kopel. Bob was trained in internal medicine, has since gone on to train in anesthesiology, and actually practices at Hoag Hospital as an anesthesiologist in Newport Beach, California. But while Bob was with me, he raised the question of, well, why can't we look at everything possible on these patients, and maybe we can figure out exactly a predictive index that would let us decide who's really going to do poorly if we send them out. My objections to the previous studies, and I hope yours would be too, is that they're not, when you compare the mortality of the patients coming back to the unit, they may have simply been the sicker patients that came into the unit. And when you compare that to the mortality of every other patient that didn't come back, you're probably picking out a lot of patients who go to an ICU with minor problems for monitoring. So the overall unit mortality is probably not the right comparator for patients coming back to the unit. So what we did was we created a matched patient for every patient in our in our study, and that's called the case control method. So we looked at every patient readmitted either to my surgical intensive care unit, which I was running in those days, or an 8-bed medical intensive care unit, and we picked a single patient who had the same age, same sex, same unit, and same diagnosis. Now, we didn't really have a traditional scoring system for severity of illness in effect in those days, so we just kind of looked at the overall chart on admission and tried to decide that that patient was probably as bad off and had as higher risk as a patient that had come back to us by looking at their initial admission. This study took us about a year. We looked at a total of 117 clinical and laboratory values on each of the patients where they were available, and used that for analysis. Our overall readmission rate for both of those ICUs combined was 4.6%. However, just as we noted in the earlier studies, the mortality rate was exceedingly high, and even with our case matched, probably close to same risk patients, the mortality was huge. 41% of those 82 patients compared to 7.5 of the patients we'd chosen as matched controls. Their length of stay was considerably longer, as you might guess, and that accounts for their increased cost. Their hospital length of stay obviously was long as well. So what we found when we did multifactorial analysis of these factors were that we had a couple that were different. For instance, patients who were readmitted had an increased respiratory rate. However, if you look at the numbers, 24.2 versus 20 on the average, I don't think any of us would be easily want to hang our hat on 4 breaths per minute difference in a recorded respiratory rate. Likewise, those patients were slightly more anemic, but 32 versus 34 really doesn't help us much in a clinical environment. Positive fluid balance did reach statistics significance, but once again, the difference was relatively small. There were only 6 patients who had positive blood cultures in either of the groups, and they were all in the readmitted group. A very significant correlation, but since there were none in the other group and there were only 6 in the readmitted group, it wasn't very helpful either. So we were left with the same problem that we really couldn't predict from any of the variables that we could find in the chart who was more likely to come back than somebody else. I will remind you that 30% of our readmissions on that study were for worsening of the original problem, and 58% had respiratory failure. Hence, we were quite interested in patients in preventing respiratory failure, whether it was original diagnosis or not, and what we could do to maybe ameliorate this excessive mortality in patients coming back. So what we figured out now, you've seen data from 3 studies of individual ICUs and one of a hospital with several ICUs, and what we've seen in all these patients are that if you come back to an ICU, you have an excessively high mortality, 4 to 10 times higher than patients who didn't get discharged and then return. Being admitted for the same diagnosis may carry a worse prognosis, or it may represent an inappropriate discharge. Hence, there's an interest in looking at these folks as a quality improvement or a triage improvement process. Hospital length of stay and costs are undoubtedly higher for the ICU readmit patients, even when corrected as best we could for the severity of injury or illness. And respiratory issues are a very common reason for the ICU readmission. Hence, it's important, I think, for respiratory therapists to understand this epidemiologic problem that we have, and because you can provide potentially a solution. Now, no single factor or combination of findings at initial discharge predicted with any certainty who's going to come back. That was true in our study and all the studies that we could actually identify in the literature at that time. Well, as you know, readmissions, sentinel-type events and percentage events are being used to grade hospitals by various and sundry folks, and hospital mortality rates are now available readily for your hospital and mine online. The question has been raised over the years whether ICU readmissions, because in fact hospital readmissions are being used as a way to reduce reimbursement if it's for the same problem, but are ICU readmissions really a useful measure of the hospital performance? So in this relatively large study by Cooper, some interesting things came out. First of all, they looked at a huge number of patients in the Cleveland, Ohio area, over almost 200,000 ICU patients admitted in 38 ICUs in 28 hospitals. So it's a huge data set. The predicted risk of in-hospital death and ICU length of stay based on age, ICU admission source, diagnosis, comorbidity, and physiological abnormalities were carried out. This is the Apache 3 Acute Physiology and Chronic Health Evaluation Scoring System. It's a proprietary product, and a number of institutions, obviously, in this area, the area of Ohio, use this as a predictive model for outcome. What they do with that is they look at all the patients in the hospital, predict the mortality outcome, and then see if the hospital's actual performance compares favorably, meaning it's less deadly in their hospital than predicted, and that's a good thing. These severity-adjusted mortality rates, length of stay, and hospital readmission rates were also determined, not using the Apache system, but more conventional reporting structures. This is the rate of ICU readmissions for each of the hospitals in that reporting system. And what you can see is that the ones with the little dots above them, these four here, had statistically significantly lower readmission rates, and you can see 4% up to 6%, which was about the average. And you can see that the teaching hospitals in black had the worst, and two of which were statistically significantly worse than the others. The day that patients tended to return to the hospital was relatively early. Approximately 30% returned within a day. Within 3 days, 15 to 20 within 1 day, and then the remainder, about 30%, were readmitted after about 7 days. The median time was 3 days, 35% were within 1 day, and discharge, and 22% occurred more than 7 days following discharge from the ICU. It would seem likely that the earlier readmissions would reflect inappropriate or inadequate treatment, early discharge. It would seem that the later ones were possibly due to the development of a new problem. And I think it's important to separate those two concerns because the treatment may be different for each. In this large data set, the most common diagnosis for readmission was cardiopulmonary, and the initial readmission reason and the readmission reason was only identical in 20% or less of patients. So they weren't picking up a strong signal for early discharge. Even after they accounted for the severity of illness, risk-adjusted hospital mortality was more than 7 times higher in patients who were readmitted. So even with their predicted, this sort of confirms what we did with our case control study, that the patient's mortality really wasn't predicted by their initial presentation or physiologic parameters. Neither was it predicted that they would come back with their physiologic parameters at the day of discharge, but if they came back, they had a very much higher mortality rate than either of those would have predicted. I only put this up here to show you that there were a lot of differences between ICU admissions and those that came back to the ICU in this database, and I think you'll appreciate that they had a higher Apache 3 score, 54 versus 43. That makes sense. They were sicker when they began. Their mortality in this case was 15%, and their length of stay was a couple of days longer. So all of the things we mentioned about individual units and individual hospitals seems to hold true in aggregate. What was remarkable about this study was that hospitals that had worse performance on mortality indices for overall patients did not, in fact, have any association with readmission rates. So those were not associated with hospital length of stay mortality. However, the authors of this study suggested that the insensitivity of the ICU readmission rates at a hospital level, i.e. the higher mortality in patients who are readmitted, suggests that ICU readmission may represent a useful sentinel event around which to target ICU quality improvement programs. And in a sense, that's what we're sort of doing today. it's not just in the United States where this readmission problem exists, and this was another study in several hospitals and in 7 ICUs in Canada. As you'll note, the readmission rate, although a little bit lower than some of those reported above, was varied from anywhere from about 5.5% down to 2.5%. You can see how many patients, quite a few less in this study, but you'll see that these are the reasons and the outcomes for readmission. So patients initially admitted, and the percentages of initial admissions and readmissions were pretty much scattered across the board. However, the majority of patients who developed and actually were readmitted came because of respiratory illnesses, respiratory compromise, and it suggests that perhaps that's an area that should be paid a lot more attention. So we've now seen that individual units, groups of hospitals, and now we're going to look at groups of published papers suggest these same or similar problems with patients requiring or ending up being readmitted to units. The first significant one was written by Dr. Rosenberg, and I met him because he actually called me up. He did a meta-analysis of hospital readmissions. Here are some of the international data papers that he reviewed. He also included a collection of ICUs in the United States over the previous 10 years. And 2 of the groups actually were the 2 studies that I'd mentioned from the University of Virginia. The first one was the case controlled, and I'll get to the second one shortly. What's important is that there's a wide variety of readmission reasons. Sometimes it's the same, sometimes it's new. The readmission rate, as we've seen before, varies quite widely in these reported studies. Some are multiple institutions, some are single institutions. The number of patients included is quite large in some and quite small in others, but you see the variation there. And then finally, mortality. So if a patient is readmitted with the same problem, their mortality in each of these studies is significantly higher than if they're admitted with a different mortality. 33 versus 12, 30 versus 38, that one actually went up. 30 versus 26, pretty close, but a little bit up. So there's a trend toward, if you're admitted with a new illness, you do better than if you haven't had your first illness repaired. The 2 studies here are the ones that I participated in, and you'll see there's some blanks in there because they're not organized exactly the way this data is. The first one you've already heard, 47% mortality in those admitted with the same unfinished treatment versus those admitted with a new treatment. I'll get to the second one further on in the presentation because it represents a different approach. So this is just a summary of those studies of why they were readmitted, and as you can see, the dark black are respiratory reasons, the gray, the second bar, are cardiac, and if you were to add those all up, you would see that in all those studies, those are the predominant reasons patients end up back, either cardiovascular instability or respiratory instability. As you might expect, being readmitted to an ICU lengthens your second stay. In those studies that we mentioned before, 5 days went to 6. In this study, 3 days readmitted, 5 days went to 6. They went down a day on the second admission. This one went up a day. In my study, patients on their were readmitted for almost twice as long as they were for their first day. Ignore this one for the moment. Likewise, this stay was longer, was about the same as their average ICU stay. This is data in these studies is not entirely comparable, but on the average, patients tend to stay as long or longer on their second visit as they did the first time. This is the mortality of those studies, and it varies from 58% in these studies. Mine was 42%, and it was as low as 21%, and as I said, I'll get to this other piece of data in a moment. So back in 1994 or 5, when we were doing this work, we had the opportunity to move from one institution that had a single medical ICU, a single surgical ICU, and actually double our ICU beds and separate them into services. So we had a cardiac unit, a neuroscience unit, a medical ICU, and a trauma and transplant unit. So we now had 5 or 6 units where we had 2 before, and we had about twice as many beds. We also had the opportunity to address the readmission problem by changing the way we delivered respiratory care to patients who were discharged to the floor. And what we did was we established a respiratory care team that saw every patient who was discharged from the ICU within 24 hours of discharge, was well known to the nursing staff, and acted as a consultant service if anyone was noted to be in trouble or just wanted to talk about pretty much anything. We then looked at the patients that went into all those 5 units where we had 2 before, and you saw the data, and I've been sort of talking about it secondarily. We went, although our readmission rate stayed the same, our mortality in those patients that were readmitted dropped from 42% down to 12%. And we were quite pleased with that change. We couldn't associate it because it wasn't a prospective study. It was, once again, retrospectively looking at what happened after we made this change in ICUs and service. It's not directly comparable because it's a different period of time to our first study, and that's why it's hard to integrate this piece of data specifically into those comparators before. But what we know now, or what we believe we know, is that the readmission rate is and should be somewhere between 2 and 12%, depending on the type of unit in hospital. Teaching hospitals usually have higher readmission rates because to some extent they are related to the illness of the patients they treat. The crude rate should include only patients who survived the first discharge. One of the problems with the early studies were if you got out of a new unit and died, then you wouldn't get readmitted, but you were probably discharged too early, or perhaps you shouldn't have been included at all in the counting process. And we really there's no general consensus on what to do with patients like that. So the rates themselves are kind of deceptive at the edges, at least. But we do know that this is a big problem, as you've seen in all the studies I presented. Well, another way of looking at patients coming back to an ICU is they probably did have an event happen on the floor. This was a relatively recent study in the past year trying to look at what do we know about patients coming back to ICUs. Are there predictable things, or not just coming back to ICUs, but coming from the floors and being admitted to an ICU? That would be part of the patients who got readmitted to an ICU, but it would also include patients who came in, were never in an ICU, and then got admitted. Can we identify events that occur, and can we prevent them? And this was looking at what's the published data in looking at that issue. Well, these authors found approximately 1,116 records that they thought they could analyze. When they went through them, they found out that most of them really didn't have useful data or weren't related to the subject. Of those, 84 full texts were looked at and they were read. Most were excluded for not having chart review, didn't report adverse events, and they were finally left with 29 studies that possibly included the stuff they wanted. And the conclusion of this particular study was that the meta-analysis could not be performed because there were too many quantitative discrepancies in how the data was reported. So they ended up reporting a table of all the possible things that they saw. I will point out that they thought that premature discharge was certainly, from an ICU was one of the events that led to readmission, in this case admission to an ICU. And there were a number of other things, such as 39% of them had to do with procedural and equipment materials. I know you can't read this, but I would just tell you it's a scattergram, and if you were trying to pick out a reason to keep a patient in the unit, you wouldn't find it on that chart, or you might find it, but it wouldn't help you very much. Their conclusion really was that the currently available evidence is relatively weak, and it is not possible to estimate the overall incidence and preventability rate of adverse events that necessitate ICU admission. Variability in methodology, definitions, and poor reporting in studies may be the main reasons, so this can be researched in order to improve the quality of care. Hospitals should better document the reasons for admission on ICUs. Well, that's nice to say. As you all know, that's not a high priority when you're taking care of sick patients, and you can almost say that about many of the things we do. They commented, though, that several authors recommend early detection of patients with clinical instability on general wards and the implementation of rapid response teams. Step-down units or intermediate care units can be a useful strategy for patients who require monitoring to avoid ICU readmissions. However, the effectiveness of any of these systems still needs to be confirmed. As you know, there's a mandate really to have a rapid response team today. In a sense, we were kind of thinking that was why our patients did better in that secondary study, by having a roving therapist team during the day identifying patients who might be at respiratory risk, which accounted for 60% of our readmissions. They were picking them up earlier in the course of their deterioration, getting them back to the ICU in a facilitated manner, and providing appropriate care quicker. And that may be why our mortality dropped. We did have exactly the same readmission rate in the first study period as we did in the second, which adds some validity to at least our discharge process, I suppose. But having patients quickly evaluated and identified before they deteriorate seemed to be our clinical outcome that we thought that's how we were affecting clinical outcomes, although we don't know for sure since it's not a controlled study. I jumped ahead here, but surgeons have their own ideas of, so switching gears now. So there's really not a lot of information on whether a step-down unit makes a difference or not, whether early involvement of rapid response teams make a difference, but we all in our heart believe that's true. So these are the efforts that we put forward to both preventing and treating readmissions, but also preventing ICU admissions anyway, or taking care of them in an earlier fashion. The surgeons bring up another interesting point in this paper, and they noted that preventable deaths due to errors in trauma patients and otherwise survivable injuries account for up to 10% of fatalities at level 1 ICU trauma, or level 1 trauma centers. 50% of these errors do occur in the ICU, so it's a high-risk area. And the root cause analysis of most of the, or 76% of Joint Commission sentinel events is communication errors. They looked at, they just watched surgery handoff of care over a period of a week or two, and they found that critical laboratory data was frequently not passed on, that ventilator care was not passed on accurately or at all. What lines were present and when they were supposed to come out was not passed on. Antibiotics, cultures, and meds the patient was receiving. For a total of the patients they observed, at least 20% of the errors were seen in that observation period. They then put in a checklist to see if they could correct or ameliorate this, and indeed they did. They reduced these percentages in every area except perhaps consults, but that's maybe not so important since there were so few of those anyway. But all the others were statistically significantly, the total and each of the various areas. So in fact, a checklist, here is the one they used for this particular study, a patient handoff of care checklist. It listed all of the major areas where information was needed, and then simply should you check something and when, have you done it, check it off here. And one of these for each patient was the way this was used. So checklists are becoming an important component of correcting the problem that we have on identifying those patients who might be at risk. So critical patient information is commonly degraded over a 24-hour time frame in the ICU due to poor communication between team members. A structured checklist significantly reduces the incidence of lost information and communication lapses between trauma ICU members at handoffs of care. We postulate that this reduces the incidence of patient errors in the ICU, although they didn't specifically test that. There's other literature on handoffs, this one specifically in physicians. Once again, this was designed to be a large meta-analysis of published information on handoffs, and they started with clearly over 2,500 potential publications, and they ended up with just 46 in review, most of which were not scientifically valid studies, but included editorials and non-randomized and retrospective reviews. Their conclusion was, despite the negative consequences of inadequate handoffs, very little research has been done to identify best practices. Most of the existing peer-reviewed papers and studies had design or reporting flaws. On the other hand, there is a remarkable consistency in the anecdotally suggested strategies. However, there remains a paucity of evidence to support these strategies. Overall, there's a great need for high-quality handoff outcome studies. Of course, that's true, focused on system factors, human performance, and the effectiveness of structured protocols and interventions. And some of these are going to be, in specific little areas like trauma patients in an ICU, but they may be in broader areas, as we'll talk about in a bit. This is an interesting editorial, basically. The patient handoff medicine's formula, one moment. So it's something that's got to be done quickly, and it's got to be done accurately. If you don't tighten that last lug, the car won't finish the race. They ended up describing 25 discrete incidents of communication failures associated with resident sign-out. The following two major types of dysfunction were noted. Those associated with omitted content, meaning they forgot something, and those with failed processes of communication, meaning they didn't communicate it well, prioritizing it, the data. Despite the cultural differences among nurses, respiratory therapists, and physicians, they stated, and because the issue of communication skills is within the human factor realm, there's every reason to believe that the handoff solutions for each of these human groups will be more similar than different as new system solutions emerge. So they're at least giving us therapists, or those of us interested in therapy, top billing in solving this problem. I'd like to mention this paper, which isn't quite a checkoff, in fact, but it was written by a respiratory therapist, and it has some interesting implications. So the value of adding a verbal, oops, hang on guys, I can do it. I can do it slowly. There it is. The value of adding a verbal report to written handoffs on early readmission following prolonged respiratory failure. This comes out of the Mass General, I believe, and Dean Hess is is the first author. And what they do, they have a long-term ventilator unit or long-term care unit that they send patients from the ICU directly to. They may be receiving mechanical ventilation, or they may just be at a respiratory risk. And what they actually do is they send them out there, and what they noted was that patients were being readmitted at a rate of about 10% coming back. So instead of simply sending a checkoff sheet with the patient to the unit, they started calling the long-term care unit and making the handoff by telephone while the checkoff list was being read. So those patients that were readmitted versus those that were not readmitted, there were no demographic variables that identified any specific group or type of patient, whether they were receiving ventilation, oxygen therapy, how old they were. There really were no significant differences in any of these demographic variables in who was readmitted. When they looked at whether or not the patient received a call as well as the handoff, they found a significant p-value in multiple regression analysis, and the odds ratio was significant. So if the patient, caregiver to caregiver phone call, there was a less than 50% chance the patient would come back. All of the other variables they looked at, with the exception of pulmonary comorbidity, really did not have much impact in whether they came back or not. But if there was a handoff of care call, that made a significant impact. The odds ratio of readmission, as I said, was 0.42, and the readmission rate dropped in the ensuing months from 10% to 5%, and the resulting estimated cost on the average was about $148,000 for every 100 patients discharged. So this is a communication issue and a handoff of care improvement activity that really paid off. So the AARC, of which I assume most of your members, has been involved in creating useful tools for its members for a number of years, and recently has gotten into looking at checklists as potential opportunity for patient improvement and patient safety. They did that with a grant, and they assigned, or they asked for volunteers, and ended up with a number of committee members. Patrick Dunn, myself, Wade Jones, Jim Shuk, Doug Lair, and Tom Kellstrom formed the committee that looked at several potential checklists. The first one, well, the process involved selecting the literature much like a meta-analysis, where you do a literature scan, a Medline search, and then you select the papers. In general, we ended up with about 200 papers to look at. Then we each read two of us read at least two of them. We got together by phone and came up with suggested components to the checklist. And then we spent about 3 or 4 months looking at layout, adding, subtracting, trying to hone the text and the prettiness of it. And then finally, when we had something that was almost tolerable, we sent it out to membership and said, would this be helpful to you, and do you have any suggestions? And then we modified them and placed them on a website. The first two you may be familiar with. This was sort of our first effort. We came out with a patient safety, inpatient safety transport, I'll read it to you. Patient safety oxygenation monitoring during in-hospital transport for pediatrics and for neonatal and infants, and for pediatrics and adults. This slide you probably can't read, I can't, but I'll take you through some of the pieces of it. It consists of a patient readiness portion, the person getting ready to leave or turning this individual over to someone else would record the heart rate, respiratory rate, the observed oxygen saturation. If indicated, for instance, if it were a neonate and you wanted it not to be above 80% or 82%, you could have a set no lower, no higher than. The current supplemental oxygen or not, and how it's delivered, and the respiratory pattern, some estimation of it, whether it's relaxed, rapid, shallow, or irregular. Then we had decided that it would be important to have a monitoring device readiness as well. Alarm settings would be included, whether the pulse oximeter components were in good shape, and that all the controls on the oximeter, if that's what was being used, were actually working and that the audio and visual alarms were functional. That it had a full or a partial charge, if it's checked how much charge is there, if that's a possibility, and where the sensor placement, either pictorially, such as on the hand, finger, or toe, or could be indicated on the earlobe left and right. So where it was measured might be important and might be good to tell someone. Now the other half of this was that we frequently underestimate how long transports from one place to another or while you're there will be required to run on oxygen. So we made it very easy for the person receiving this patient to look at the oxygen in the tank that they're using, and so this guideline was included showing the oxygen cylinder and when you might be running out of oxygen supply. We made it a little bit pedantic in that we asked for the time the oxygen cylinder started and the estimated time that it would deplete, so that you had to look at the charge and then figure it out. So that if these two are filled in, then you know that the individual's actually done the calculation, or at least attempted to. So it acts like a check-off on the receiver as well. I saw a question that are these forms available? If you go to the AARC website, these are the checklists. This is the link to get to that. Checklists help during patient transport. It was posted originally on February of this past year. And if you click on the blue Get the Patient Safety Checklists, this is what you get. And then you can download in PDF formats those two forms which we've just looked at. Now, we're in the process of putting together a adult risk assessment checklist for respiratory care related ICU readmission. Much like the oxygen transport, this would be an individual patient process. It would be done at the time when discharge is being considered, and it would have several components. This is what the form looks like. I'm guessing it's actually online now, or at least we hope it will be shortly, if not. And it should come pretty much through that same route when you look for checklists, patient safety. So it has a similar organization, and I'll take you through the components of it. So there's patient information. This would be, your routine name, age, height in centimeters, and height in inches, and I'll get to you for why that might be important, and weight in kilograms. Admitting diagnosis and any comorbidities that are of concern, and then the individual who's taking this handoff would confirm by checking yes. The status at pending transport, because we're actually building this not to the transfer is actually going to occur, but in fact you're considering it. A number of things came out in our literature review of importance, such as patient level of consciousness, how well were they breathing spontaneously, and as you can see, we've included a number of potential ways to measure that. We hypothesized that 15 cc's per kilo of ideal body weight would be a reasonably sensitive monitor, but we have not tested it. That's sort of textbooked, if you will. We included ideal body weight calculations over here, and that refers back then to those weight in kilos and inches above 5 feet. So that's why we have both inches and pounds and inches above. Is the patient able to protect their airway, gag, and cough? I happen to work in the neuro ICU, so I'm very sensitive to those components of the physical exam. And then you as respiratory therapists want to know what they're on oxygen-wise. Vital signs, the last recorded value for blood gases or non-invasively monitored. Some people like a spontaneous or a SpO2 on room air. And then if there's anything else relevant on this particular patient, there's room to write that. We then sat around and tried to decide what are the most important things that we found in our readings that might help you be more sensitive that this patient might have an issue after he leaves the unit. And we came up with these. If the patient carries a diagnosis of sleep apnea, currently receiving dialysis, received mechanical ventilation in the unit for more than 3 days, I guess that's a day and a half, sorry, 36 hours, supplemental oxygen greater than 50% at the time of transfer, a critical care length of stay greater than 2 weeks, unable to deep breathe, not making that 15 mils per kilo ideal body weight, or no cough or gag, you get a check for either or of those two things. Abnormal level of consciousness, and we call that uncooperative or comatose. And then abnormal vital signs, a respiratory rate less than 6, greater than 24, heart rate greater than less than 50 or greater than 110, or a systolic pressure over 200 or less than 90, or abnormal blood gases, as you can see there. What we thought might happen is that people would check these boxes, and they would come up with 3. They would write a 3 here, and then they would look down below, and this is a moderate risk of returning, 3 to 4. If you've got 4, it's getting a little more scary. If you've got 5, you're probably going to come back. Although we have not tested this, it's only a suggestion. These forms shall be available for both use or modification to your local institutional values if you so desire. What I also think would be useful of these would be to kind of test these things. So as you start, if you think these are useful and you start using them and you want to tell us you think they're useful, I'd be happy to help you set up a study that might actually collect some data and confirm whether or not they do help. Remember, all the research up to this point really hasn't shown any relevant, well-done studies to confirm that checkoffs do actually help and improve outcomes. So this is the from lots of studies over many years, we know that all of those variables are associated in one way or another with doing poorly after leaving an ICU, and that's where we decided to pull them from. We had trouble deciding on the weight, so you might want to change those numbers as you get into it, and we probably will too. This is a process, not a project, and it'll continue. What we do know is we have a very seriously ill group of patients that do very poorly under routine circumstances, and at least some anecdotal and some controlled studies that suggest if we get to them and treat them earlier, we're probably going to improve outcome and save lives and money. And maybe we have some way to risk stratify those patients as they leave the ICU and identify those that maybe ought to be seen more frequently or go to a step-down unit. I thank you for your attention. I know that's a long hour and a lot of information. I know there have been a couple questions, and I think now's the time to entertain them. Doug, back to you.
Well, thank you, Charlie. This was a phenomenal presentation, and I certainly appreciate that. I would like to open this up for questions one last time. Just as a quick FYI, the checklists that Charlie highlighted this afternoon, both the oxygenation checklists as well as the ICU checklist, are all available on the AARC website under the resource section, and then you would click on patient safety checklists, and that the ICU checklist is available on our big button, and we'll have a story on that checklist and the importance of ICU readmissions coming up in our July edition of the AARC Times. So real quick, Charlie, before I let you go, I do have a quick question for you. In your study in 1993 that you shared at the beginning of the presentation, you talked that of your readmissions to your ICU, approximately 58% of them were respiratory related, and I know that this could potentially be a problem with not just your institution at the time but others. Were there quantifiable measures or parameters that would differentiate between a patient readmitted, for example, with a CHF issue versus a respiratory issue? I know that many hospitals can their respiratory department or their pulmonary physicians or intensivists might look a little bit, get a little mud on their face if we have overly high readmission numbers for respiratory, when in fact they might have been cardiac related. Could you just speak to that for a second?
Sure. I can't tell you specifically whether the respiratory diagnosis for readmission was cardiac or respiratory per se. Certainly the cardiac cardiopulmonary interaction, a bad heart makes a bad lung, and certainly the treatment of cardiac-induced respiratory failure involves respiratory care, i.e. positive pressure ventilation. So I wasn't personally that concerned. All of those patients came back in respiratory distress and required some form of respiratory intervention. Most of them required intubation. Nowadays, they probably would be treated with non-invasive ventilation. We did not have step-down units in those days, so that those patients would probably be patients who had not ended up on a floor initially, or perhaps would have been transferred to a step-down unit if they'd met the criteria on such checklist as we suggested. I think it's imperative. I thought I was being judged by my readmission. So when we did all this work and our readmission rate was identical, to the decimal point, it was 4.6, and it was 4.6 3 years later, despite all the respiratory care work we'd done. I was kind of disappointed. On the other hand, I think it's not your rate that counts. Just like ICU readmission rates didn't really correlate with hospital quality measures, and I don't think you ought to take it personally. I think actually what we were really pleased with was that our death rate from readmissions, specifically at respiratory, fell 10%, but overall they fell a huge amount. So we were having more survivors by simply identifying them. I know that doesn't specifically answer your question. I'm doing a little aggrandizement there. I think doctors have to be careful about taking credit or blame for system problems. In fact, this wasn't a physician problem. This was a system issue, and it will be a system issue for as long as we both shall live, because systems take care of patients, not doctors or therapists. We contribute, but we don't. It's not us. It's the whole system that has to function in a meaningful way. And physicians aren't particularly good at taking responsibility for systems. That's enough, I guess, on that.
Fantastic. And of course, this is just merely a tool for respiratory therapists to red flag these patients at greatest risk. But then there could be a whole new process that could be built around how you treat and take care of these patients once they're out on the floor, which is a completely different issue. But Charlie, thank you so much for spending your afternoon with us. For those of you who are watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE credit hour. If you are watching this program as an archive, this concludes our presentation.